Hi, good morning, everybody. Good morning, Tyler. I'm very excited for our third episode of the podcast today. I have here a special guest and a friend. Let me go ahead and introduce him. Dr. Tyler Evans is the CEO, Chief Medical Officer, and co-founder of Wellness and Equity Alliance. He is an infectious diseases expert, a public health expert, and has been on the front lines of many major disease outbreaks, including 2 Ebola outbreaks. Outside of the US, he's worked in sub-Saharan Africa, South Asia, and the Middle East with organizations like Doctors Without Borders and Partners in Health. In the US, he was the first chief medical officer for New York City in the emergency management response for COVID-19 pandemic. He's also the Adjunct Associate Professor at the University of Southern California, Keck School of Medicine, in the Department of Population Health and Public Health Sciences. It goes on a little bit more, which is he is now recently an author of a new book, Pandemics, Poverty and Politics, Decoding the Social and Political Drivers of Pandemics from Plague to COVID-19, which is just out in August of 2025 from Johns Hopkins Press. So thank you, Tyler. Thanks for being here, and it's great to have you.
Great to be here. Thanks, Gaurav.
Do also want to quickly just mention a minor conflict of interest. I did work for Wellness Equity Alliance for about a year and a half, maybe 2 years, and I own a small percentage of some shares in the company. So I just wanted to put that out there. So Tyler, tell us about, your early life, maybe from childhood to about 18.
Sure. Well, I think a life a lot in chapters recently, given my book. So if it's helpful, I can kind of break up my life into 3 chapters. So the first chapter, by the way, is this video and audio or just?
Yes, both video and audio.
So I got to make sure my hair was,
Hair looks great. Yeah.
Great. Thank you. So first chapter really was the seeded my entire sort of journey, right? And so it started with some privilege. Stepfather was a pilot. Mom, it's a long story. Mom was a Playboy bunny at one point. They met in the Bahamas. They did well. Started in New York, moved to Los Angeles, actually when I was in utero. Fast forward, my biological father was actually a physician, OBGYN. So had that privilege. Throughout my life, there was a lot of disruption. My mother suffered from depression and chronic alcoholism. And my stepfather was laid off from, he was at Pan American, was a very famous airline, and they went bankrupt. So our resources were significantly impacted. And so that privilege was then sort of eviscerated. And, we were not living in the streets, but we were in a pretty tough spot in my kind of early sort of teens. And so for all those reasons, that sort of led to a lot of frustrations and sort of adolescent rebellion. And, I had some, challenges. I also had two children at a very young age, one in my teens and one in my early 20s. And so all of that was sort of connected to a big eye opener for me, which was sort of hit rock bottom at one point, and I had an opportunity to get an education. My mom had passed away. My whole family passed away by the age of 21. But I got into University of Southern California, stroke of luck. As I got into USC, I had this choice. My mom had actually passed away, so I couldn't accept the first year that I was accepted. Ended up getting in, matriculating the following year. I hopped in. Internet was just born. I didn't really understand a lot of the educational modalities. I had a community college education. I dropped out of high school when I was 16 and got my GED. And so here I am at USC with all these privileged, kids. They call it University of Spoiled Children, with this sort of checkered sort of past. And Gaurav, what I found myself in was opportunities to connect with folks that had struggled, that had experienced challenges. And some of those were down on the southern border of California in Tijuana, Mexico. So there was this group that used to go down there once a month, a bunch of docs. And so undergrad and med students would go out there. And so seeing that those stark disparities and that sort of, that very visceral reality of people not having much and struggling. And particularly that intersection between the haves and the have-nots was very striking for me. And what I felt was a connection to people that experience adversity, that experience challenge. And at that point, that was a lightning bulb for me. I was like, this is something I want to help these people somehow. Now I was super junior in my journey and my sort of, career development, but that was an inspiration. The next inspiration was I had the opportunity to start to go to Uganda and then South Africa in the late 90s and early 2000s. And at the time, the HIV/AIDS pandemic had really exploded. So going to certain areas, seeing 40% of certain provinces infected with HIV, that's almost one in every two people infected with this virus that a lot of folks did not have access to medications and were going to die was super compelling, right? And the pharmaceutical companies had the medications, but it was out of the hands of, virtually over 80% of the folks who were infected. I mean, at the time, over 70% of people infected across the world were in sub-Saharan Africa, and they didn't have the purchasing power in order to sort of, procure the medications. So myself and a lot of other people were involved I interned with Doctors Without Borders, and that again was that sort of next lightning bolt moment. So that's chapter one. Chapter two was, I had these compelling experiences, I got into to graduate school, to medical school, Columbia University, Ivy League University, spent some of that actually in the Middle East, started doing a lot of traveling, worked in the Palestinian territories, worked in Kosovo, worked in a lot of other sort of conflict areas. And that sort of solidified the journey that I was going to go on, which was global health. And so when I got done with my residency and my fellowship, I went out. I spent a lot of time in the global south, working with Medicine Sans Frontières, Doctors Without Borders, working with partners in health. I worked in the Ebola response twice. I worked with Indian Health Service. I worked with Native Americans with some of the most sort of dire conditions that exist in the world. In fact, in my book, Pandemics, Poverty, and Politics, I actually create some scenarios where I say, okay, I create a scenario that takes place actually in Wyoming. I create a scenario in South Sudan, and I asked the reader to guess which was which, right? Because they essentially are almost sort of like impossible to sort of tease out. So all of those sort of experiences really kind of consolidated, the journey for me. And what it also allowed me to consolidate or affirm was the fact that while the magnitudes of the burden of disease are considerably different in the global south versus the US, although not so much when you look at, Native American reservations and other areas, and to some degree, certainly the magnitudes are different, but the drivers are very much the same. So I'd be working in South Sudan, I'd be working in the South Bronx, I'd be working in South LA. I have a theory on the Souths. Um, and and I'd see very similar conditions, right? And they were seeded by the social and the political drivers. So that sort of influenced my thinking considerably until I got to chapter 3, which was starting to move into leadership, and to work in areas, work not just with patients, but with systems, and being able to inspire and work to develop young healthcare professionals to kind of go on this sort of the right track.
Before we go to chapter 3, because I love the way you're telling us the story, because I think what I enjoy hearing from most people is really the arc and how are their decisions and how are their career evolving from the experience they're having, right?
Mhm.
But one thing that he said, which was really struck a chord, is how the drivers of health are so similar, no matter where you may be working for a lot of people. There's a project we worked on in the past. It's trying to do some mental health education for PCPs in the Democratic Republic of Congo. But I've done that same education for PCPs in San Diego. Right. So it's literally exactly the same level of education that is needed in both settings and is missing. The other question I had was, I grew up in India, and you spent a lot of time in the global south. So there are obviously resource poor environments, right? So there is less money, less resources available. But what did you see in that system that was positive, something that was different, was missing when you work in the US. Was there some part of the system that worked well there? Was it a social support?
You mean in the global South? What were some positives that I saw?
Yeah.
Yeah, sure. I mean, there absolutely were strong positives. In fact, India has actually a lot of resilience. Their public health infrastructure, while I mean, it's been over 20 years since I've worked there, but while their public health infrastructure was relatively anemic, you're able to kind of distribute resources in a relatively effective way. So that's a very important element. South Africa, despite everything that I just said um, about what was happening in the 90s, it was partly the HIV epidemic because I mean the apartheid exists until 1990 and so partly as a result of the pandemic, South Africa has an incredible public health infrastructure, and a lot of that is community health workers. And it took community health workers exist actually in India as well. Community health workers exist in many parts of the global South because they don't have enough licensed healthcare professionals. And it works. It works really well. And from an HIV standpoint, which is most of my career, if it were not for those community health workers, the South African public health infrastructure would have just sort of imploded. It doesn't because of these CHWs, and it worked really well with the nurses. They call them sisters, and they're tough. So that pairing is really cool, and that's what we use a lot with street medicine, right? We use a nurse and a provider, but actually typically it's a nurse and a CHW. So that dyad is really important. So yes, so there are elements that do exist that work very well effectively in the global South. And you look at Cuba. Cuba, it's a training model for public health institutions across the US and across the world in general, but particularly in the US. And it's the irony of Cuba being this pariah of Americans, and yet we're studying their public health and their healthcare system, and particularly the costs. The costs, I mean, when we look at healthcare expenditures in the United States, we are number one across the world, and particularly among OECD countries. We spend roughly 2.5 times more than the second country, which is Germany, on healthcare, and that includes public health. What are our results, right? I mean, we are a sick country, and it's getting worse. I mean, when it came to the morbidity and the mortality as attributed to COVID-19, I mean, we were essentially the worst. And yet you take a country again like Cuba, you're spending 10% of the healthcare expenditures that we're spending, and the outcomes are effectively the same, if not better, in Cuba. Why? Because they focus on primary care and population prevention, which doesn't cost a lot, and they give it to everybody, right? So when you have that sort of that parity and and distribute it to all, you have very, very positive outcomes. So yes, I think we can learn a lot.
And obviously, in your work and what we're doing here today in the US, we are using community health workers so much more than we did in the past because
Yeah.
there is such a huge impact that they can have.
Yeah.
You were telling us about your starting on the journey of being an entrepreneur, building, Wellness Equity Alliance.
Sure. So in the third chapter, I again was sort of influenced by the previous two chapters and wanted to do something differently. And then so through the arc of my leadership trajectory, I was tapped to be the first chief medical officer for New York City during lethal and formidable pandemic that we've seen in 100 years. So obviously that was a pretty big job, and didn't sleep much. I'll never get my hair back. And the problem was we had all of these resources. We had all this funding, right? I mean, between FEMA, New York City, New York State, I mean, we were throwing, hundreds of millions, billions actually at these programs. We had in the very beginning, we were using high-rise hotels for isolation and quarantine, healthcare worker hotels before we had anything, right? We needed to kind of just figure it out and sort of try to sort and protect as much as people as we possibly could until we could get the testing, until we could get the vaccinations. The contact tracing didn't really work. And so we had all these resources, but it didn't really work. We built I was at the where the US Open is played, ironically. And the city ended up spending, I think, like 57 million, and they got like 78 people into this facility. Why? Because people didn't trust the systems, right? This was New York City. This was still government. It's a progressive city, but it's still government. And so people didn't trust the government. I mean, we had the 45th president there. I didn't call him his name. And at the time. And so people naturally, we had all these different opinions about what COVID was and all that misinformation. So people were confused and they didn't trust. And it just further polarized the distrust that we have in systems and science, et cetera. And so that was probably like the final compelling moment for me where I said, we've got to do something differently. And so I came back to California and I was one of the incident commanders for mass immunizations in the Bay Area. And because, previously I had this really, useless skill set of understanding the difference between, isolation and quarantine and mass immunizations, usually childhood mass immunizations, completely useless in the US until the pandemic hit. They're like, oh, this guy actually knows some stuff that could sort of be helpful. So that worked out. Anyway, so I'm up there and, we built these large pods, points of dispensing for folks. And, the folks that I was seeing there, we used to jokingly describe them as the triple Cs. Because there was the different eligibility periods. Typically, it was age in the beginning, and there was essential workers. But the folks that we saw, no matter what the eligibility periods were, in the very beginning, the folks that we saw was a very clear pattern, and it was Caucasians with cars and computers, right? And I was looking at these patterns and was like, this is not right. The folks that we need to protect are Black and brown communities, are communities that are the most historically marginalized, because those are the folks that are at the highest risk of not just infection but adverse sequelae. So I guess with my sort of operational knowledge, I had this opportunity to jump into private sector. And a friend, mentor of mine, essentially asked me. He was running the testing division of this company called Curative, and they ended up scaling, roughly like 10%, but at the time, roughly 10% of all COVID-19 PCRs, which was a lot, and made a lot of money doing it. And then they wanted to pivot into the vaccine space, into the clinical space. And so, he said, I know a guy. And fortunately or unfortunately, rarely say no. Well, and I'm working on that. So I said, yes, in this regard. And in the beginning, they asked me to just be a prescriber. A week later, they said, do you want to be the medical director? And then, 2 weeks after that, they said, actually, do you want to be the CEO, president, and CMO? So said yes to it all, quit my day job, and ended up doing what we were doing out there in the Bay Area, and we just scaled it. And we ended up doing over 2 million COVID vaccines. We did over 1 million in California. We're doing, places like Dodger Stadium, we're doing upwards of 14,000 shots a day. But what I was really proud of was focusing on not just the scaling, but focusing on the surgical specificity to focus on the most historically marginalized. So and it was funny because we had some private equity folks who were all kind of ex-military and they just really wanted to make money. And I'm the social medicine doc who's trying to say, yeah, but you got to focus on these guys, right? So, and fortunately I had, sort of cadre of docs that supported the vision. So there was some differences that we had for sure we were down the southern border of Texas. We were in South Central LA. We had small little, mobile units that were going out to these areas and protecting people. And a lot of these folks had probably not seen a doctor or a medical provider for years, decades, if at all. So that was a really compelling experience. And, we were in Flint, Michigan, which is famous for their public health issues and other places. And we got invited to the White House. Once that sort of dissolved, a group of us basically got together, said, hey, we really did something pretty cool here. We got to keep the band together. So we did, and sort of that formed, that was the genesis to form Wellness Equity Alliance. And I didn't know anything about the business space. I was pretty good doc. I was a reasonable operational director, but business was not my thing. So with the last company, we generated over 47 million revenue in like 6 months, and we didn't even know what we were doing. With Wellness Equity Alliance, we really didn't know what we were doing. And I actually did not want to take the helm. When we were in, I took another job as medical director for healthcare for the homeless in Alameda County, which is Oakland and other areas, pretty, terrible homeless conditions. So I was running 14th Street medicine teams there. And we got to Sand Hill Road, which is famous for the venture capitalists in Silicon Valley, in like 3 months. And then we ended up getting a grant. And one of my former business partners said it takes like 10 years to get to Sand Hill Road. And we did it in like 3 months. So I got the meeting, and then literally the next day we got this grant, a small grant, but it was enough to start doing some stuff. So I quit that day job. And I didn't want to take the helm. for several months, we're just on meetings with these docs who are like, oh, I think we should do this. Well, I think we should do this, And so some folks are saying operations, some folks are consulting, and a lot of docs talk. And we talk a lot, right? There's every 6 seconds, I think, patients are interrupted by physicians. So that was the last data point that I had seen. But so a lot of folks were just talking, not really doing anything. And so one of my advisors, mentors, told me at one point, they said, you have a natural gift for leadership. And he said, at one point, you just have to take the helm. So I did. I took the helm and I said, like I said, I quit my day job, brought the team together and I said, all right, let's do this. So we stood up an operation in Texas, and then one thing led to another, and here we are.
Yes, such an interesting arc. You describe yourself as the social medicine doc, the doc who's kind of worked in the public safety net space for so long. When you first started this in the private space, what is the biggest switch in leadership that you had to do, or you saw this is different than what I was already doing? Like, obviously, you're working towards aligning it really well, but what is the first big change in your thinking that you had to bring in?
Sure. Great question. Money. And the reality is, I, like a lot of other sort of social medicine docs, have a allergy to the sort of the finances, right? You start talking to the finances, and we're like, it doesn't matter, we'll figure it out. Or we think that sort of, capitalism or consumerist sort of markets are the enemy to sort of healthcare or the work that we're doing, right? Because the reality is, it does seed polarization and whatnot. But the reality is, money is the oil or the gasoline to all engines. So whether you're in a nonprofit, whether you're in an FQHC, whether you're in government, or whether you're in the private sector, it's all the same, including universities. It's all of the same. It's all funded by money, right? And so if we are not thinking about the money, we will never really understand the possibilities for our patients as well as for the systems that support our patients. And there's this famous expression, no margin, no mission, right? It took me a while to really drink that Kool-Aid. It took a while. It's a steep learning curve to really understand the business, but I'm really happy that I did, and I now can do more because I know how to sort of braid together these revenue streams and diversify in this very sort of complicated federal disruption that we're dealing in right now. Listening to my advisors, listening to financial advisors, listening to physician advisors, and again, really thinking about how we can do more mission with more funding. And I'm really proud of that. And I often say, and I know this is nails on a chalkboard to a lot of folks, but when I'm talking to other CEOs or business leaders, I'll actually say, like, our number one objective is not profitability, right? It is mission. And yet it is a driver, but if you're only focused on profitability, right, you're never going to be great at what you do, right? Because that is your God. But if you are focused on doing something really, really well, the money, it's a little more complicated than that, but the money will come. Right. And so, but you've got to embrace, and you have to connect the two. And I think that's what that innovation I'm really proud of at Wellness Equity Alliance, because we're able to, when we first started talking about privatizing public health, right? People were like, what? It was just such a foreign concept to folks. But the reality is, public health does not work as well as it should. And it's not public health, lifelong career folks. I don't want to send that message. It's not the message. The message is that they're not set up for success. Look at the CQC right now, right? A good friend of mine just resigned, as well as, a lot of other folks there. It's not set up for success. And even before the politics have always sort of been there. And so, again, these public health agencies are not set up for success. And so when infectious disease outbreaks lead to epidemics, which then lead to pandemics, the reason is because we don't invest in the social infrastructure to ensure that the folks that are most at risk are protected. And they don't trust the systems. This is not just an American problem. This exists across the world.
Yeah.
And until we do focus on that, we're going to continue to see more of the same.
Yeah, I'll tell you, the reason I first got attracted to Wellness Equity Alliance was the principles you're just talking about, is that let's try to make it work. I had done my MBA, so I'd begun seeing that even though I want to do the best for my patient, but the path to there is through financial sustainability, right? And I think that just makes your mission stronger. You can do it for longer. You can keep expanding what you're trying to do. But I think that really makes a huge difference. But at the same time, in healthcare, I've been on meetings where at the county where people say, oh yeah, $2 billion is coming down for this purpose. And the first comment on that is that's not enough money. And to me, that says you obviously are not spending the money right, and no amount of money may be enough for this if it is not spent correctly, right? I think what you're trying to do obviously is allocate the money more effectively, first from the goal of making sure you're doing right by the patient in front of you and the community. And doing it in that way helps you retain staff, helps you keep the team going. Also, it is a tougher path because you're investing so much upfront, it is tougher path to profitability, but it is definitely attainable.
Yeah, absolutely. I think I got the question there. Being lean when it comes to, to sort of funding, you can do a lot with a relatively little if you are thoughtful about the business model. And that's what, one thing that inspired me a while back, there was a big earthquake that hit, well, actually the big earthquake that hit Pakistan and the one that hit Nepal as well. And particularly the one in Nepal, I had some Indian physicians that went out there. And they had their own little NGO, and they had done a sort of cost comparison between WHO, Doctors Without Borders, and their group. And there was orders of magnitude sort of difference between these. Overall spend on the World Health Organization, there's so much fat, and I'm not trying to demonize WHO, but in general, these bureaucracies that exist, there's built in so much fat into it that actually getting the services to the end user, which is, the citizens of, country X or Y, is very low, right? In comparison to all of the expenditures that exist. Like I was saying before, the healthcare expenditures in the United States, we spend the most by far, and yet the outcomes are nowhere close to where they should be. And at least 1/3 of the country cannot or will not engage in healthcare in the way that it's set up. There's good evidence for that. UCSF published something recently on that. 1/3, probably closer to 1/2 of the country does not know how to engage in healthcare because of the complexities, because of funding shortages, et cetera, et cetera. Medicaid, for example, in California, if you are not an FQHC, Medicaid pays you for a moderately complex visit, which is roughly 30 to 45 minutes, pays the institution $37. Why would a doctor or healthcare organization accept that, right? Like, unless you're mission driven. And I used to, prior to running a business and organization, I used to judge the docs that wouldn't take Medicaid. But I get it now. It's the system is rigged. The system is not set up for success. If you are saying you're going to have to eat these costs, if you're going to see these patients, of course, a lot of private practices or whatever are not going to accept it. So yes, okay, the HRSA creates that backstop, creates, an opportunity to do that, but not everybody can become an FQHC. Not everybody wants to become an FQHC.
I've worked in FQ space and county space. I think even the frontline physician and the team member who's trying to do their best, they're not set up to succeed. They're not set up to give that patient who needs that extra attention, more attention, right?
Right.
So early in my career, I would say, why is this person not doing the best possible? But as you look broader, you start seeing people are not set up to do their best work. The thing I tell a lot of young clinicians is if you're passionate and if you're good at what you do, you have to try to step up into leadership roles. And if you do not do it, somebody else is going to run the system not as well. So my thinking is when you ask for-profit companies, like, the large insurance organizations, which are very profitable, don't always do the right thing for the individual patient. There's a lot of pushback out when we question how things are done. But also, the WHO and the publicly funded institutions, when you question when things are done, as you said, there's a lot of fat in some of these organizations and how they implement, right? There is significant amount of pushback there too. Do you agree with that kind of exists in both those worlds?
I think that there is a relative degree of fat that needs to exist, but we can do a lot better when it comes to cutting through that fat. Looking at the university model, for example, which obviously many universities provide direct clinical service. When you're looking at the indirects that some of those universities, I won't name who, some of them have indirect of 80%. Okay. And so I can understand how taxpayers would get, provoked by that. And that's, the current sort of disruption that's taking place with the academic space. I strongly disagree with it. But these universities don't need 80% of sort of taxpayer money out there, sort of indirect. Some needs to exist, but we need to do a lot better when it comes to sort of cutting through it. And I think that there is a general assumption, right? Like institutional folks are not often incentivized for change. Like your larger hospitals, they don't want to change because they've been doing this way for their entire careers. So why would they change it, right? They don't see the gaps. They don't see the opportunities to expand. A lot of these folks are not macro thinkers. Unfortunately, institutional thinking leads to arthritic sort of outcomes. And so I think you really need to be in the foxholes, like I have, like other members of our organization have, to really understand it, to really say, guys, this isn't working. Right? This is not working. The systems are not functional right now. They're not aligned. You look at EMR systems, right? You have all of this innovation that exists in EMR systems, but they don't talk to each other, right? There are some, reasonable attempts to get them to connect with HIEs, health information exchanges, but it's still not ideal. Actually, Wellness Equity Alliance have been trying to do this in LA. There's a HIE that exists. So apparently we have to, just to get a scholarship to participate in it. And scholarship only pays you half of the actual fee, which is like $25,000 to be a part of this exchange. We have to do this like systems analysis, which is going to cost us like $20,000-$30,000. So effectively, it's like $50,000 from our system to connect to this other system so that we can help these patients, because we're seeing homeless folks and we want to know where they've been, what hospitals they've been touching. Even though obviously, like, it benefits everybody, the health plans did not understand street medicine. They didn't understand how to pay for it, because the way that it's set up is once somebody is assigned Medicaid and assigned that plan, they then start receiving that money, right? And then they auto assign those patients to typically an FQHC, and the FQHC auto assigns it to a PCP. So somebody gets a card somewhere. I mean, if they're homeless, who knows where that goes? But they've never seen this card, and so the health plans are absorbing that money. They're not incentivized to do anything, because they're getting the money to just sit there. And then the FQs are receiving some. They give them a certain amount of time, and if they don't see the patient, then they're penalized. But it's not the FQ's fault. It's the health plans, right? The health plans are just sitting there on the money. Finally, when you get good health plans, like, I'll name it, Inland Empire Health Plan, amazing folks, right? They get it. And, they understand that, yes, we might have to pay twice, but it's the right thing to do. Because ultimately, we are going to save money, because that person will be engaged in healthcare. And when you look at, the actuaries that kind of run these numbers, the dollars that you have to spend on somebody who's unsheltered, unhoused, without primary care is really profound. And then if you throw in all of the complexities that we often see, right, with the decompensated mental health issues, particularly psychosis or schizophrenia, serious mental illness, typically decompensated. You throw in addiction and you throw in infectious diseases, the costs are profound if you're not providing the services. So, the health plans are finally starting to get it, and we're finding Wellness Equity Alliance is finally starting to get street medicine contracts to provide direct clinical service and actually become their PCPs. And through initiatives that the California Street Medicine Collaborative has pushed out, particularly spearheaded by University of Southern California, particularly the USC Street Medicine, Brett Feldman, who's the director of that. They've gotten some bills passed that are now allowing providers to be considered the immediate PCP, as opposed to doing this change that'll take months to longer to change that PCP. So the systems are changing, but they're still very dysfunctional. And they're getting, again, given all the changes that are currently taking place, it's getting worse. And who gets hurt in the end are the citizens.
What's interesting is, you and I are the systems thinkers. And when we look at what makes us system thinkers, I think, to me, the key is we are always connected to the ground reality of what's happening, not just to our patient, but to our team. You're out there in the
Yep.
street medicine team. I feel like if you're disconnected even for 6 months as a healthcare leader, actually on the ground feeling the pain of your team, you're not going to design a system that is going to work for either party, the patient and the frontline. Do you think that that is the key?
100%. I think the most, that's what I was getting to earlier. The most effect in healthcare, or really in any space, the most effective leaders are the ones who really get it. And you have to, and it has to be, it's not static, right? Like, it has to be dynamic. It has to be sustained, right? So you literally have to keep your finger on the pulse. Um, I know psychiatrists don't, I just made a joke. I said, I know psychiatrists don't do that often, put their finger on the pulse, but
Yeah.
it's really to understand the team, the patients, because that helps influence you to do better. And that inspired me to innovate, change, because I felt it, right? I had lived experience, and I knew that I could do more. And as a doc, I was stuck and the system's sick, right? So to be a doc that can sort of address the system is something that was very compelling to me. And that's my life mission at this point, is to address these systems and try to do whatever I can in my little world to heal the systems.
How do you keep changing the way you're thinking about a problem? Because I think what I found in my last role, I was there for about 6.5 years. And just maybe 6, 8 months before I left, I was thinking about a problem, and I realized my thinking now was very similar to when I first encountered the problem 6 years ago. And it was very jarring, the kind of the dysfunction I saw in the system back then. So it almost like is a timestamp memory for me. And I was thinking in the same way again, even though the system around me is already changing. How do you as a leader keep evolving your thinking? How do you do it? Do you do it by reading and speaking?
Yeah, it's a good question. I do it by, yes, I mean, staying connected to the ground, staying connected literally to the streets. I'm constantly talking to thought leaders and sort of different systems thinkers. I just got off a call with the CEO of the International Association of Providers of AIDS Care. He runs something called the Fast Tracks Initiatives. They have over 500 cities that are engaged in sort of innovative HIV service delivery. And so he really loves the idea of HIV street medicine, and he wants to help sort of create a diffusion of that model around cities across the US and across the world. So, that just got me thinking about a lot of things. And we just started sort of synergizing. We were talking about writing guidelines for HIV street medicine and then bringing those out to the thought leaders like New York State, California, to credential or credit them. And then we could scale those concepts further across the country. So yeah, it was just a concrete example of what literally I was doing right before this. And yeah, so talking to people, yes, reading, it's hard. It's hard to read, because so many hours in the day. But yes, I do try to read as much as I can, in just quick hits here and there as much as we possibly can. I try to stay away from social media. We have to get out of our echo chambers. And I've always had a commitment to sort of the democratic consumption of knowledge. I was trained in medical neutrality, working with organizations like Doctors Without Borders. So it doesn't matter who the bad guys or the good guys are in a particular war, you treat everybody the same, right? So applying that concept to the consumption of knowledge, I know that almost all knowledge is biased, right? Particularly history. So for example, when I was living in the Middle East for several years in Israel, Lebanon, and I worked in Palestinian territories almost every weekend, I would read Noam Chomsky, who's a very liberal philosopher, who's actually a philologist based out of MIT, who would give me one perception. Then I would read somebody named Alan Dershowitz, who is a Harvard law professor, who's very conservative about the Zionist sort of movement. That, but somewhere in the middle is the right answer, right? Same thing with the news, right? I will toggle. My news source is Google News, so I will toggle between your sort of your Fox News or whatever, Breitbart, and your Al Jazeera, your MSNBC or whatever. And again, somewhere in the middle is the right. So yes, so reading, listening, being there, and the world right now is changing at such a rapid pace that you have to keep up.
Yes. That's actually incredibly helpful. Let me ask you, I think in healthcare, one of the problems I see on the clinical health side of it is healthcare organizations don't like admitting mistakes or even saying we should be able to do this better. And I think today's consumer, the patient, is a lot more informed, empowered, and potentially has a lot more ability to make choice, not in all communities, but many communities. And I see that as a huge flaw in the clinical medicine space where they are almost unwilling to acknowledge mistakes in most organizations. If you look at today's discourse, there's obviously a lot of misinformation about disease and vaccines that needs to be fixed. But at the same time, you also mentioned there was also this baseline distrust, even at the start of the COVID pandemic, even in the city like New York, a liberal city. What does public health as a field of study, as a field of implementation need to think differently or do differently over the next months, that next time, when hopefully not, but next time a pandemic happens again, the people feel more united around the idea of public health?
That's a great question. I obviously think a lot about it. And I have to preface my response by saying that in our current state, with all of the sort of destruction and dismantling of public health foundations, it's going to be very difficult to do this. But I am an optimist, and I do believe that the pendulum will swing back. And I think what's going to happen, the reason why I think it's going to swing back is because the more that we dismantle science and the delivery systems around public health, the more people are actually going to see the burden of disease scale, right? Public health, when it's working effectively, is at almost invisible guardrails or safeguards around populations. And when it's not there, almost just like a fire service, because fires are put out very quickly, right? If you do not have a fire service, a fire department, then cities will burn. And that's exactly what's about to happen, sadly. And so so people will see it, and I think they will then make informed decisions. Now, outside of that, what the public health experts and champions, what we need to do is really coordinate systems so that when there are public health emergencies, and it's not just infectious diseases, and we have a program in New Mexico around carceral health, and we're building out a reentry program. And I talk about it's a convergence of three epidemics, one being mental health, the second being substance use, and the third is mass incarceration. So we're trying to sort of disrupt that sort of convergence of these three sort of epidemics working, and sometimes I call these syndemics. What we need to do is, when these public health emergencies strike, there needs to be a clear chain of command. So one federal agency needs to state the fact, work with states, cities, counties across the country. There are organizations, you've got AASHTO, you've got NACCHO, you've got a lot of coordinating organizations that could be that. And that information then is distilled through these channels. Meanwhile, you've got the community-based organizations that are connected to the cities and counties on the community level. And they're getting that information out to their communities because of that problem with distrust. If it's just the government that's telling you X, a lot of people are going to distrust it if they're either on the left or right side. But the community leaders of their communities, their respective communities, will tell them what they need to know. And then therefore there's no disagreement, right? Like this is what's happening. Science, this is evidence-based. There is no opinion. It's not up to an opinion. Like, science is not opinionated. It is just a fact, right? And it could change too. That's an important element. Everybody, people love to jump on with Fauci said this, but he was wrong. Yeah, because science is open to change, right? Like it is open to potentially be flawed, and that's okay. It's experimentation that drives science. So science has factual conclusions, and there's no opinion there. So if we can get that to the communities and all be on the same page, we can protect our communities.
From somebody who's lived that life for so long, I think that's very helpful to hear. And I agree with you. I think the information flow should be reliable and consistent. And I think there should be less. Opinions are always going to happen, but there should be less. Should be less up to interpretation.
There's this one example that I've been discussing lately, and I think it's very visceral. It's if you're a patient in a hospital in the ER and you've got two doctors right in front of you that are actively arguing about your diagnosis and your treatment, what is your level of confidence in that diagnosis and that treatment? You're gonna want a third opinion. So it's super confusing. So people trust doctors. People trust nurses. Actually, there's a Pew study that came out 4 or 5 years ago, and it was looking at basically which professions individuals trust the most. And teachers were number one, nurses were number two, doctors were number four. And I think scientists were like number 17. But people trust doctors, people trust nurses. The more that we create this divisiveness, we're going to lose that trust. And so as doctors, we have a lot of agency. And so we have to speak out about these things. And I think our communities will listen to us.
The last thing I want to ask you is, what are the most exciting projects you're working on at Wellness Equity Alliance right now?
Yeah, HIV street medicine, that's kind of like one of our kind of bread and butter operations. We're expanding in the Inland Empire, which is really exciting. There's a lot of homelessness, unfortunately, in the Inland Empire, and not a lot of groups that are kind of in our space. We're connecting enhanced care management, street care management with these street medicine contracts, and then we're building out we just got news that we're going to be building out a mental health urgent care also in the Inland Empire, which is super exciting because it's the concept of just, no wrong door, just anybody being able to come in. It's 24-hour facility. And then we'll be able to kind of refer them out to other areas. So those are super exciting. We really want to focus on, again, the first one, the HIV street medicine, really get that model out to the rest of the US and focus on technical assistance. Our strategic priorities right now are behavioral health, rural health, street medicine, tribal health, and technical assistance. Focusing on those areas and lots of really cool programs coming up.
Tyler, it's been amazing I watched only the last third chapter of your journey, some of it, but it's been incredible to see obviously your passion and also hear the story of where that passion comes from that real world experience of doing the work. And you are really very aligned to where healthcare needs to go. So, which I appreciate you doing. And I know it's not easy at all. Thanks for having this conversation. I appreciate you jumping on the podcast, and I hope to see you soon.
It's a great conversation.
Okay. Thanks so much, Tyler. Take care.